Madam Chair. Medicare physician payment policy has major consequences on to whether or not providers can continue operating independently, whether practices can recruit and retain physicians, and ultimately whether patients can continue accessing care in their communities close to their homes. These issues are especially important in rural areas like in my district, New York's 23rd district, where losing even a single physician due to retirement or moving on to a different area or any independent practice can have significant impact on access to care for my constituents. And with that, Dr. Furr, you mentioned in your testimony the growing pressures facing physician practices and increasing difficulty many patients have finding timely access to care. In many rural communities across the country, including in my district, we are already seeing physician shortages, longer wait times, and growing challenges recruiting and retaining doctors, particularly in the area of primary care. In some areas, patients wait months for appointments, or they have to drive significant distances to get to their appointments for routine care. From your perspective, how much are instability in the Medicare payment system and growing administrative burdens contributing to these broader workforce shortages and access challenges?
You know, every year we tremble when January comes around and we know we've got another cut, and we're trying to decide what are we going to do with our practice. Can we add more staff, or are we going to have to cut staff? You just can't plan ahead. You know, I can remember a few years ago, I did a fix, but it was actually in March or April, and we held all our billings for 3 months and had no income from Medicare until we got the fix done. So that instability, you can't run a business that way. You couldn't run a restaurant, or you couldn't run a gas station that way. So that instability makes it hard to get the technology we need, to hire the staff we need. All those things make it very difficult to run a practice, and that's one of the reasons behind consolidation. One, they're benefited more by the cost of the service that they can provide, but also the cost of doing care. When I first started practicing, if my overhead was 40%, I was shocked. It's 65% today, just because of the cost of doing care.
Well, we need Medicare payment policies that are keeping pace with innovation and advancements in patient care. Dr. Snyder, as we discuss Medicare payment policy, can you talk about the growing use of cardiac PET scans and why many physicians view them as important advancement for the diagnosing and treating of heart disease?
Yeah, PET scan is what common term is a nuclear stress test. I think a lot of people are familiar with that term, but it's an innovative one which gives us additional information that we don't have access to currently. From a patient perspective, it yields 1/3 to 1/6 of the radiation, so it's a safer, better test overall. It's much more accurate. You get better images. And it gives us very good data, probably the most accurate data about does a patient have an obstructive blockage or not. So there's a lot less false positives, which lead you have to take that patient to the cath lab. So in a way, we get to defer, we get more accurate data, and we can safely say you do not need a higher invasive test. But more importantly, there's another cause for chest pain, especially amongst women. It's called coronary flow reserve and coronary myocardial vascular dysfunction. And what that is, it's a type of cause of angina with a microcirculation, the circulation you cannot see with an angiogram or detected with other type of stress tests. But beforehand, a lot of these women, we said, oh, you don't have a severe blockage, it's in your head. And we now know it's not true. They were actually having disease, they were having chest pain, and this is a condition, microvascular dysfunction, which leads to higher mortality and higher morbidity. So we can accurately diagnose it. This is the only non-invasive test available for us to actually detect this. And you see it frequently in 50 to 75% of women who have non-obstructive disease. They actually had something, and you also see it in certain minority populations, such as African Americans, actually have a disproportionately high prevalence of this condition as well. So it's a very powerful tool for really getting down to the high quality care before something goes awry. I'm a little concerned there's been some discussions about decreasing that reimbursement, in which would have a very bad access problem for us.
And in the very short time I have left, how important is it that payment policies keep pace with these newer technologies so that the patients can continue to get these new advancements? And are there any reimbursement or payment policy barriers that could slow patient access or broader adoption of the technology?
It would definitely slow the adoption, and here's the thing, it's actually saving us money. We're able to defer the more costly invasive procedures at a hospital or in ASC because we can do this non-invasively and safely and not expose the patient to an invasive procedure.
Well, thank you very much all for your time away from your busy work and God's work that you do every day. I appreciate you being here, and Madam Chair, I yield back.